Okay, everybody, Dr. Rafich here from Vet Triage. We are continuing on with this issue of Veterinary Surgery, February 2022. Greater trochanter osteotomy as a component of cementless total hip replacement in 5 dogs, or rather 5 total hips, 4 dogs. And just to give you an idea of what a greater trochanteric osteotomy is, basically what they're going to do is, in order to place a total hip replacement in the femoral diaphysis, they're going to make a cut here where this red line is, but of course it'll be straight because it's going to be controlled. This is a fracture. So they'll do the osteotomy, so make a cut across the greater trochanter, remove it, do the total hip replacement, put the greater trochanter back, and then typically you place 1 or 2 pins in the greater trochanter and then secure it with figure 8 wire. But because you have the total hip replacement there, you can't put pins through it, and so they're going to do a double figure 8 of wire here to replace it. So I'll show you some pictures of that. But basically, they're trying to do this procedure to get better exposure for the total hip replacement surgery in dogs that have abnormalities associated with the greater trochanter where it gets in the way of the surgeon. All right. So this study comes out of Texas A&M University. The objective is to describe a surgical technique and report long-term outcome of greater trochanteric osteotomy as a component of cementless total hip replacement in dogs with severe medialization of the greater trochanter or chronic cranial dorsal hip luxation. Introduction. Common indications for total hip include hip dysplasia, arthritis, traumatic hip luxation, avascular necrosis, fractures. Successful clinical outcome, 83 to 95% of dogs. Technical considerations to improve the probability of clinical success include accurate templating, femoral broaching, stem placement, among others. In human total hip replacement, the term greater trochanteric lateral version has been used to refer to deviation of the greater trochanter away from the trochanteric fossa. This is the trochanteric fossa right here. And central axis of the femur in either a medial or lateral direction. The greater trochanter lateral version can lead to specific challenges, including reduced canal exposure, femoral fracture, stem malalignment. In case of severe lateral version, techniques such as greater trochanteric osteotomy can improve access to the trochanteric fossa, identify the central axis of the femur, preserve gluteal musculature at risk for iatrogenic damage during broaching, and facilitate coaxial femoral broaching. In veterinary orthopedics, the greater trochanteric osteotomy is used to improve access during internal rotation of certain pelvic fractures. It's also been described in management of canine hip luxations and to improve exposure for hip replacement. Materials and methods. 3 dogs had severe medialization of trochanter. 1 dog had a chronic craniodorsal hip luxation of 2 years duration. Severe trochanteric medialization is defined as a femur in which the medialmost aspect of the greater trochanter was positioned on or medial to the anatomic axis of the proximal femur. So let me show you here some x-rays. They measured the anatomic axis of the proximal femur and then decided that the greater trochanter was in the way. They also saw in one of these cases concurrent proximal femoral sclerosis. The portion of the greater trochanter preventing ideal stem placement was outlined on radiographs. So this is the measurement of the radiographs here from this finger here. You can see the line down the center is the central axis, and you can see that dot where that line intersects. That's where the greater trochanter is in the way. And then the arrows in this picture here is the sclerosis of the femur. Look how white that femur is, thick, dense bone. And then the other 3 images show different variations of what would happen if they did not perform the greater trochanteric osteotomy. So C and D show malpositioning of the stem that would probably lead to femoral fracture. And then here is the image of what they're going to do. So on this image here, you can see the line that shows where they're going to do the femoral head neck ostectomy for the hip replacement. The line is dotted where they're going to do the craniotrochanteric osteotomy. Then B is the placement of the stem, of the femoral stem, neck, and acetabulum. And then C and D shows the post-op and then long-term healing. And you can see the pins they placed there as well as the wire. So they were actually able to place the pins in the greater trochanter and avoid the implant. Very cool. Okay, radiographic evaluation. On post-op radiographs, acetabular size of the cup, angle of lateral opening, degree of retroversion, and inclination angle were determined. In the frontal plane, a positive stem position value denoted varus angulation, whereas a negative value denoted valgus angulation. In the sagittal plane, a positive value denoted a craniocaudally tipped stem, whereas a negative value denoted a caudocranially tipped stem. And then they assessed stability of the pin and tension band wire, which is what this is here. Pin and tension band. Tension band because the forces here are pulling down on the greater trochanter, opposing the forces from the gluteal muscles in the opposite direction. Here's a model of what they're doing. So you can see the top row, they did the femoral head neck ostectomy, the greater trochanter osteotomy, they placed the total hip replacement implant, and then they, once they're done with the implant, they replace the greater trochanter and stabilize it with the pins and tension wire. Results. The medial cup retroversion was 8 degrees. The median cup inclination was negative 22 degrees. Median cup angle of lateral opening was 40 degrees. Median stem position in the frontal plane was 0 degrees. Median canal fill in the frontal plane was 78.1%. Median stem cell position in the sagittal plane on the medial view was 0 degrees. Median stem insertion depth relative to the proximal aspects of the greater trochanter was 12 millimeters. Median long-term follow-up, 48 months. Discussion. Reported advantages of the osteotomy in people include unimpeded access to the trochanteric fossa, improved ability to identify the central axis of the femur, and preservation of gluteal muscles during broaching. It also improves exposure of the caudal acetabulum for joint capsule dissection, eases acetabular bed preparation, and facilitates prosthesis reduction. The osteotomy improves the caudal acetabular exposure, allowing dissection of fibrous tissue, aided in accurate acetabular bed preparation and prosthesis reduction. This is of interest because a substantial number of dogs presenting for total hip replacement have luxoid phenotype of hip dysplasia and the chronic craniodorsal luxation. While the osteotomy is not necessary for many cases, it might be considered in cases of craniodorsally fixed femoral heads and/or severely medialized trochanters. Complications related to concurrent osteotomy and hip replacement occurs in humans up to 38% of cases. Most common is non-union. And the reason for that is this greater trochanter is very solid bone. Solid bone has little to no bone marrow. Bone marrow is where the healing occurs. So with solid bone like this, it's no surprise that a non-union, meaning the bones never heal, is the largest complication risk. The osteotomy has been associated with a reduced risk of prosthesis luxation in humans with total hip by providing additional gluteal tension through trochanteric distalization and by preservation of gluteal tendons during broaching. So that's cool. So even this procedure actually prevents hip luxation after surgery, which is also a common complication in dogs. So yeah, it's a cool case series. Obviously, they comment also they need more cases to improve the study, but that's pretty cool. I have never seen that before. All right, thanks for watching. We'll see you again tomorrow.